about 80% are gene positive. So there's definitely a variability and overlap between the different conditions. And in lithium, about 40% gene positive. These are different MRI images. I think the question in terms of if you have great echo images from particularly with contrast enhancement, morphologically you may be able to get we often see poor quality images even with contrast, and it can help us to get high resolution images to see what is happening. And this is a case of reverse curvature with SAM, and you see the leaflet anterior motion and obstruction here. This is more for concentric neutral ACM. It's an apical variant without an aneurysm, and this is an apical variant with an aneurysm. So I think it can add, certainly, especially in patients when you have questions. Now, the question about LVOT obstruction. Now, traditionally, we've always thought that if you have LVOT obstruction, it's almost a pathognomonic feature of hypertrophic cardiomyopathy. Now, is that really true? And I think this is very important data that came from the HCMR registry. Looking at more than close to 3,000 patients, very good cardiac MRI imaging, and also assessment of extracellular volume and genetics assessment is a registry from 44 sites. And what they showed is that, and they included the patients with more than 15 millimeter thickness non-dilated ventricle, and looked at both genetics and cardiac MRI features. And what it showed was about 18% of them had obstructive variant, which is defined as more than 30 millimeters gradient, and about 36% of the total cohort had a sarcomeric mutation. But they divided this group into ones who had the sarcomeric mutation and the ones that did not. And if you look at the ones that were actually gene positive, most of them had reverse septal curvature morphology. They did have more late gadolinium enhancement and interstitial fibrosis, but they did not have significant LVOT obstruction. Interestingly, it was actually more the sarcomere negative ones, which had the isolated basal septal morphology, and more of the outflow tract obstruction. So perhaps what we have been traditionally thinking to have to start questioning, is that necessarily true? Is it LVOT obstruction equals it's genetically positive hypertrophic cardiomyopathy? Now, what about late gadolinium enhancement? And it is very helpful, something that helps us understand the degree of fibrosis. And there is in late gadolinium enhancement, we have the concept of replacement fibrosis, that which we can visually see, and interstitial fibrosis is diffuse and which we really can't see, but can use some quantitative, innovative methods to measure it. And here's a different variations of late gadolinium enhancement. This one, the first one was gene negative asymmetric septal hypertrophy with some enhancement. This is again another gene negative patient with some enhancement in the apical variant. This is a gene positive patient with enhancement, and another gene positive patient with enhancement. We are just starting to learn these things, but there is a wide spectrum of variability in terms of the degree of enhancement. And as Dr. Proformi alluded, it's the LGE burden of more than 15% is considered to be high risk and almost an indicator for needing ICD implantation. But if you look at the actual data, you'll see that even the risk more than LGE percentage more than 10%, the risk starts to go up of major adverse cardiac events. But 15% is what's been quoted as the number to use to risk stratify. Here's more. And most of them were reverse septal curvature. Hypertrophic patients had most LGE as well as some apical variants. When you look at the genetics in the registry, about 29% had pathogenic variants, and here's a list of the kind of genetic mutations seen. About 12.3% had variants of uncertain significance. About 7 of 2,661 samples also had phenocopies, which 4 of which had Fabry's disease and 3 amyloidosis. And we found similar numbers in our TUPS genome database, where 22% had pathogenic variants. So it's not that all of the HCM patients that we see, it's about 22 to 30% that's what truly have the genetic mutations. Now let's talk about the mimickers on imaging. And sigmoid septum, which is, I think, probably the most common condition that is diagnosed as HCM, at least in the cardiac MRI lab, we often see this. And this is an example of, I won't go into the details of how to diagnose the sigmoid septum, but this is an example of this discrete septal hypertrophy. Oftentimes it's more than 15 millimeters and gets diagnosed as hypertrophic cardiomyopathy and come to the cardiac MRI lab. And here's an example of a patient who was being followed in the HCM hypertrophic cardiomyopathy clinic with the diagnosis of HCM. And this was his MRI from 2017, where the intraventricular septum was measured at 17 millimeters, and he did not have any late gadolinium enhancement. He came in for a follow-up MRI, and what we saw was that actually what was measured was not really the myocardium, but it was the trabeculation. And this is not uncommon. It's actually quite frequently I see this, or not very infrequently. So it's important to measure correctly and not include RV trabeculation. And I think that is the biggest mimicker that I see. And what it also turns out is that we're not that great at measuring wall thickness. And this is starting from inter-observer variability, and in fact, agreement between echo and MRI was significant, almost 5 millimeters difference between the methods. In fact, if you actually used if you looked at the differences, it would make a difference. 1 in 7 patients, the management strategy would change because they would not really meet the criteria for defibrillator. So this is not a small problem, and you can see the differences happen because of how the measurements are measured. Between expert readers, we all measure differently, and that alone can cause significant inter-observer variability. In terms of differentiating between true HCM and whether it's discrete septal hypertrophy, you have the family history, symptoms and presentation, and alveolar obstruction, which was previously considered more in favor of HCM. We probably are moving away from that. And again, of course, we have LGE on MRI or actual positive mutations or endomyocardial biopsy. That's more definitive. Hypertensive heart is another condition where we frequently come across, and it sometimes can be very difficult to differentiate from milder phenotypes, and there are many overlapping features, and LD may be present in advanced cases of hypertension as well. And you can remember that hypertension is a very common condition and both can coexist. And this is an example of a thick heart with